Hello, I'm Josh Atkins from Anesthesiology, and this is my colleague, Dr. Tiffany Chao from Otorhinolaryngology. And we're here today to describe some best practices with regard to managing patients who are in PPE protection, in this case specifically for the COVID-19 virus. In referencing this video, I want to remind everyone that we have several documents. These will be updated regularly and available to you through the department. One is on the appropriate donning and doffing of PPE and personal protective equipment. And the other is our infographic on intubation guidelines for patients with known or suspected COVID-19 disease. A few basic principles that I would like to emphasize are: it's important when you arrive to any patient care that you before going into the room, you elicit to the best of your ability from the primary and the emergency care teams treating the patient whether or not the patient is under COVID precautions. And that will help you to determine how best to care for the patient. And it's critically important that you not rush directly into the room before confirming where they are in the COVID rule-out status. It's also important to recognize that when we're talking about personal protective equipment, that we are talking about a time process to don and doff that gear. Importantly, you must consider that that's going to take some time, and it's critically important for population health, both for avoiding us spreading that to other patients, and also to keep the providers healthy to care for the anticipated influx of patients, that we don personal protective equipment, particularly when managing airways or doing aerosol generating procedures. And therefore, it's imperative to recognize that we should not perform aerosol generating procedures without the appropriate protective equipment. Appropriate protective equipment we're going to walk through today could be either a powered airway purifying respirator, a PPE, or an N95 mask. And when the N95 mask is used, it's critically important that it be used together with eye protective gear. That eye protective gear, for the most part, will be brought during emergencies, but could include goggles and or a mask over the N95 that has a face shield. The N95 should only be used if you know the proper size and it hadn't been fit tested. The donning and doffing process can be a little bit tricky. You want to first place the mask on, then put the top strap above your ears, then put the bottom strap below your ears. When doffing, the most common mistake that people make is self-contamination by reaching for the mask. Best practices for doffing. And doffing of respiratory protection should always be done after you've exited the patient room. Doffing procedure will be to lean yourself over a disposal area, to remove the bottom strap first without touching the mask, and then to remove the top strap second without touching the mask and drop it into the container. You may arrive at a patient's bedside that is suspected for COVID infection and find that the patient is coughing, generating secretions, and is not appropriately covered. We're recommending that the patient be given a surgical mask, not an N95, but just a routine surgical mask to at least cover their mouth and nose while other providers are preparing appropriate protective equipment. So this will be done primarily by the primary teams before they leave the room when they have a COVID suspected patient. The other thing to recognize is the clinicians caring for these teams are as much as possible going to be erring on the side of early intubation, as we've learned from colleagues across the world who have treated COVID patients. In this regard, we should be seeing less truly emergent airway management and more urgent management that allows for planning. We're trying to limit and reduce the amount of high flows that are used for patients with suspected or confirmed COVID, and therefore we're reducing the use of high flow nasal cannula and non-invasive ventilation and going to early intubation once patients exceed 6 liters of nasal cannula and are unable to maintain a SAT of 92% or higher. Ideally, patients in this condition are intubated in a negative pressure room, but this isn't always possible. Consideration should be given to the possibility of transporting the patient with their face and nose covered with a mask to a negative pressure room if this is feasible.
First, we're going to go over preparing to go into the room. So you want to treat it as if you're, say, going into an MRI room. You want to remove anything that could be contaminated. That includes your badge, any watches, your phone, since you won't even be able to access that while you're in the room anyway. Your bag, if you have any supplies in there, you want to leave the bag outside the room and take out any supplies that you think you might need. Obviously, for these kinds of patients, you want to have very careful planning before you go into the room and think about anything you might possibly need beforehand, because communication from inside the room to people outside the room is very limited since the door will be closed. Plus, getting an extra hand will be either very delayed, as they'll need to also put on PPE, or potentially not possible since we're trying to limit the number of people in the room and the use of PPE that might be available, including a PAPR. So just all of those things you should keep in mind before going in. So once you've taken off all of your things and gotten your necessary supplies, you're gonna gel your hands, perform hand hygiene. And then, so like Dr. Atkins said, this is the PAPR. So it has a battery pack here. You're gonna clip this onto your scrubs. This has already been decontaminated. Obviously it doesn't hurt to wipe it down again with a hydrogen peroxide wipe. But what you're gonna do, this is a ratchet on the back to kind of adjust it to your head size. You're gonna pull it over your head, pull down on this shield area here underneath your chin, and then you'll plug it in and turn it on. The face shield is disposable and can be replaced. But for now, in case of a shortage, we are disinfecting them between uses.
And importantly, you're never going to be alone in the donning and doffing, and so there'll be people here to assist you by doing things like helping you to get the cable behind your shoulder, plugging in the battery pack, and generally guiding you if you have any questions.
So make sure the elastic is kind of all the way around your chin. It still should be in front of your ear so you can hear, but you want to make sure there's a good seal there. You'll see there's lights on the top. When you first plug it in, all the lights will turn on. There's going to be red, yellow, and green lights. They'll all turn on, and then a few of them will turn off. If you see green, that means it's charged, it's ready for you to use. If you see red, or if it turns red while you're wearing it, it means you have an hour or less left in battery life. If it's yellow, don't use it. It means the filter is not working.
And just to read it at that point, if you're doing a procedure like an airway and it goes from green to red, you have an hour of additional time. There should never be a time where you should feel panicked to rapidly exit the room and change your protective gear.
Okay, great. So now we're going to put on the gown. The gowns that we're going to be using are the 3-fold gown. So it has 2 sleeves and then 1 hole to secure the gown. So, you can put this on yourself, essentially. You don't have to necessarily have somebody gown you. You're going to put that over your shoulders here. You'll want this kind of vest hole to go over your right arm. And then you're going to put on your gloves. You can do hand hygiene again before you put on your gloves.
And we do encourage everyone to use the buddy system. When you have people and you're together, you're watching them put on the gowns and their gear. They're watching you, and you're helping each other and making sure you're appropriately donned.
You want to make sure the gloves are completely over the cuff of your gown. You're doing perfect. All right, great. So now we're all appropriately donned. We're going to go into the room.
And what you're going to find, you may find, and we as the experts may be those that come and realize that there's the bacterial and viral filter missing. So what we're going to do is, if you come in, this will be at the bedside. And if this filter is not at the bedside, respiratory will have it. And if not, any filter from a ventilator is equivalent efficacy. And so that filter should be interposed between the mask and the bag. This high resistance circuit requires you to gently squeeze the bag once to open the valve.
The protocol that we're doing now is only one attempt. If that attempt fails, then it goes straight to an LMA, and then the team will stop, regroup, and assess what the next most appropriate course of action would be, whether that's a reattempt with a direct laryngoscopy, a fiber optic through the LMA. That would be determined by the team on a case-by-case basis. So once the patient is intubated, they can be hooked up to the circuit, again, making sure that the viral filter is in line with the oxygen delivery device and the endotracheal tube, and making sure that ventilation does not start until the endotracheal tube cuff is inflated, just to make sure there's no air leakage. Obviously, if an urgent surgical airway is needed as well, these are all just things to keep in mind, wanting to avoid positive pressure, trying to minimize the spread of aerosols if that were to be the case. So once the procedure has been completed, then we're going to walk toward the exit of the room, but don't leave yet, because you're going to start to doff and remove your personal protective equipment by the door here. So what you're going to do is you're actually going to first gel your gloves. Do that. And so then, using your right arm, your right hand, you grab that best piece of the gown and then pull it off. You can try to wiggle it out perfect. And then you can use your other hand to help reach around and pull it off. Then what you're going to do, so with that, you can release that, just make sure it doesn't flop too much. You're going to grab the chest of the gown, don't grab in by the collar as not contaminating yourself, then slowly pull off and away from you. And then what you're going to do is slowly, in a controlled way, just roll up the outside of the gown so that it stays on the inside. You can kind of keep your hands in the sleeves as you're doing. And then once you have it rolled up, you can pull the sleeves off of your hands. You can try to keep your gloves on. That's probably easiest. Drop the gown on the ground. And then pull off the gloves, dirty to dirty on the outside, and then you can use your index finger to flip the other side off. And then toss it in the trash. You're going to gel your hands again. And now you're going to exit the room. Because you've just opened the door, you have to gel your hands again. And now you're going to take off the PAPR. So you're going to put gloves back on again, because we're assuming that the PAPR is contaminated. And then with your non-dominant hand, you're going to reach for the ratchet on the back, lefty-loosey to loosen it, and then grabbing the ratchet, you're going to pull the helmet off and away from you.
And most people are going to unplug
And
it.
then you'll already be unplugged by an assistant over here. Just wire out here. And then you're going to take a series of 8 different peroxide wipes. For these purposes, we'll just use a couple. But it's going to be left side of the helmet, center, right side, one for the mask, one side for the inside of the mask, one side for the inside of the helmet, one for the wire, one for the battery pack. And then you'll pass it off to somebody who will do further decontamination of it.
And in many circumstances, there's going to be an assistant outside the room who will be helping you with this decontamination process or taking it away from you. And the other thing to recognize is there are slight differences due to local experience and variations in equipment at Presbyterian Pennsylvania Hospital and HUP, specifically with regard to whether one wipes the PAPR before they take it off or after they take it off, and precisely what yellow gowns are being used and how they're being doffed. But those variations are rather subtle, and we would recommend that this practice that we've demonstrated is consistent and you can use it across the system, but if you're given guidance from an infection control person at the bedside to just follow the local practice, and they will walk you through that.